Welcome, everyone. This Best Practice Briefs is a partnership initiative of the South Dakota Foundation for Medical Care and the Great Plains Quality Innovation Network. My name is Stacy Fredenberg. I'm the Director of Development and Outreach for SDFMC, and I support the Community Coalition work of the Great Plains Quinn. Before we begin, there's going to be a few housekeeping items that we're going to review. Today's session is being recorded and it will be posted at sdfmc.org on the Best Practice Briefs page. I'll provide that link for you in the chat later. All lines will be muted throughout the presentation, so please add your comments or questions to the chat and we'll address them at the end of the presentation. While most individuals work to avoid the emergency department, others consider it a source of primary health care. When emergency services are overused, the cost of healthcare increases across the board. So this series is going to explore strategies for encouraging proper use of emergency departments. Today's speakers, Jess Danko and Mindy Hoyer, will focus on exploring interventions to improve emergency department utilization. The Partnership to Advance Tribal Health established an affinity group focused on addressing emergency department utilization in tribal health facilities across the nation. This group, it fosters a culture of open dialogue to identify strengths, weaknesses, barriers, and challenges. The open communication provides the added benefit of identifying interventions and sharing best practices to improve emergency department utilization. Thanks for sharing today. Please begin your presentation.
Thank you, Stacy, and thank you for having us today to share our quality improvement work that we are doing with the PATH team. I am Jess Danko. I am a quality improvement advisor with SDFMC and work with the Partnership to Advance Tribal Health. My background is in healthcare administration. I also have a respiratory therapy background and recently became certified in infection prevention in the long-term care. Mindy, I'll turn it over to you.
Sure. Welcome, everybody. My name is Mindy Hoyer. I am also a quality improvement advisor for SDFMC, working on the PATH project, which is the Partnership to Advance Tribal Health. My background, I'm a registered nurse and also a certified surgical technologist. We thank you guys for coming today. So what we're going to talk about today, these are our objectives. We're going to explain the purpose and engagement within the PATH affinity group, describe common emergency department barriers and challenges the group has identified, and identify interventions and promising practices for improving emergency department utilization. Next slide, please. So the Partnership to Advance Tribal Health, what is PATH? So what we do as PATH QIAs is we collaborate with IHS hospitals to transform patient care and improve the health of American Indian Alaska Native communities using patient-centered, evidence-based, culturally appropriate sources while addressing the unique healthcare quality challenges. So what did we do as PATH members to look at ED utilization and ESI accuracy within our emergency department? We decided to host an emergency department affinity group, and we got together to collaborate on ED utilization and ESI accuracy. We brought individuals across organizations with common interests, drive, and commitment together, and we shared a vision in improving ED flow and use. So what is an affinity group? An affinity group is a small group of individuals that is brought together by a commitment and a shared vision to participate in collaborative discussions and then also to foster an environment of trust with a goal to improve ED flow and use. So how we worked together as an affinity group. There were 4 different advisors on the affinity group, and we encouraged attendance and participation in collaborating discussions to foster an environment of trust and mentorship. And we did this by having 6 learning sessions with 6 check-in sessions. And we did this all within a 6-month period from September of 2022 until February of 2023.
I just want to add in for our affinity group, we really encourage participation from the frontline workers, those who really had a vested interest in the emergency department. So yes, the quality improvement staff are important and instrumental in this work, but we wanted firsthand experiences of what they're seeing, their experiences, what they feel barriers are, those type of things. So you really have a good understanding of who attended these affinity group sessions. And then also keep in mind, this was open to the IHS facilities across the nation. So we had 6 areas from across the nation participate in, ranging from Phoenix to Oklahoma, South Dakota, Montana, etc. So really a nice group of participants from a broad spectrum of areas, both rural, urban, etc. Mindy, do you have anything more to add on that?
No, that was great. Like she stated, we had all sorts of people that attended. We really wanted the frontline workers that really dug deep into the ESI accuracy and ED utilization, but then we also had representatives from area offices, etc. So it was a great group of people that joined.
All right. So in this affinity group, we brought to them a lot of questions. Part of PATH is to present these IHS facilities with milestones. So trying to achieve things like ESI accuracy or reduce wait times, your throughput times, monitoring those and trying to improve on those. Different areas like that in the ED that really impact that patient care and overall emergency department use for the patient and efficiency for the staff and those that are working in it. What we came to gather from these conversations is there's a lot of barriers and challenges and probably things that are pretty universal across the entire United States. One of the big ones is staffing. Shortages is a huge thing. We're hearing about that in healthcare all the time. We know that it's an ongoing issue. And really, how do you cover the shifts? How do you make sure you have proper staff to take care of the patients that are coming through your doors? With that staffing shortage, what many facilities have really resorted to is, well, we can't get staff from our local area. We're going to have to go to this contract staffing. So what that means is, especially for the IHS facilities, but I can see this being true across the nation and probably in our rural settings, more so than maybe the urban, is maybe they don't have a great understanding of the culture, those that they're serving, and maybe how something like a rural population that's going to an IHS facility sees their healthcare in comparison to how somebody in an urban area that has multiple avenues for healthcare really utilize it. The other thing with contract staffing is they're not necessarily given a long orientation process. Yes, practices in healthcare are pretty universal across the board, but there's those things that you do in your facility that are unique to your facility. So whether that's referral processes or how we get somebody to the next level of care. So being able to really carry that orientation so contract staffing is able to understand your processes was seen as a big barrier. And then knowing too that some of these contract staff are only here for really a very short period of time. So how much time do you really invest in comparison to how much time do we get them in and seeing patients? Another big barrier that we've come across, which is no surprise, but it's communication. We need to be able to communicate from provider to our patients, from provider to nurse, and really communicate with our patients and families. So there's a lot of levels of that. Some that were common themes that we're sure probably can be relatable to your facilities too, is how do we communicate top down, so that administrative level, that director and nursing level down to those that are working the front lines, that are that emergency department nurse or that nurse's aide that's over there assisting, where they're really frontline, firsthand experiencing what's going on. And then how do they communicate back up to you what's the processes that are happening, suggestions that maybe can be changed or help to improve the process, and is there open lines to be able to get that communication across? So with that being said, are you holding a huddle weekly, monthly, that regular ongoing scheduled huddle to share, what's working, what happened today, ideas for improvement, suggestions, that type of thing. So really looking at, are we communicating? Are we making it easy for our staff that are working in this emergency department to share with us what is going on so we can make those improvements? Because without that communication, you're going to run into ongoing, continuous issues that really don't ever get resolved. The other part of communication that becomes really important here is that caregiver to patient and family communication. So what's clear, what do they understand versus what I'm trying to communicate, those type of things. And we'll talk about a little bit of that later. Another barrier is that timeliness. So when we say that, we're talking about what's the availability of office visits, those primary care provider appointments. Is that what's really jamming up our emergency department? Are there no appointments available? So of course, these patients are coming to us rather than maybe looking for other care options. And then within the emergency department, really looking at the timeliness of your medical screening exams, and your triage times. And then trying to gain an understanding of that left without being seen becomes a big barrier, trying to understand why patients are getting up and just leaving. So we'll talk about some of that a little bit later here. I mentioned before, communication, patient education is a barrier, especially when you're talking about different cultures, different areas, like I mentioned, the rural area. And something we're seeing really across the board is that limited availability for after hours care or those care options. Anything more on that, Mindy?
No, ma'am, you covered it.
Yeah, thanks. So some of the interventions that were discussed is really that care option education. So if you have the opportunity to have a walk-in clinic, extended hours clinic, an after-hour phone line, how are you getting that education out? Do you have flyers hanging in like a primary care clinic? If we think about that, you know what, that's great. We have a flyer promoting it. But what about those patients that aren't even able to get an appointment in your primary care clinic? How are they supposed to be aware of this? Social media is a great avenue, but keep it in mind, your older population maybe doesn't utilize social media, or the younger population probably doesn't use social media in the same avenue as maybe your middle-aged patients. And then thinking about things like, do you have opportunities for radio to kind of share that education on what care options are? So just some possibilities there with interventions. For those of you that maybe do have these opportunities, like an extended hours clinic, are you even maybe passing out flyers within your clinic? So when a patient gets home and needs to come back a week later and can't get a regular appointment, they think, oh, that's right, there's extended hours. So just really keeping in mind those interventions and being really thoughtful of how are we trying to communicate this? Because, yep, we can try it. And if we extend our hours on a Wednesday from staying open till 5 till maybe 7 at night, and we don't have anybody come in, what are we going to think? They don't want to utilize it. They'd rather go to the ED, different things like that. When the reality is maybe we just haven't gotten the education out there. The next intervention is really looking at your emergency department follow-ups. So what are your follow-up phone calls after? What's your process? Is it a nurse's responsibility that's supposed to make these follow-up phone calls? And is that list maybe getting passed from one nurse to the next because they just don't have time to do it? So really understanding, are the follow-up phone calls happening? How quickly are they happening? Because you all know if somebody's been in the emergency department, they likely need a follow-up. So making sure to call them, check on their symptoms and make sure they got that appointment made. Really looking at that process. The other thing that is a great intervention that came out of this affinity group that some of the facilities were trying as we talked through this was they went with getting the primary care appointments made directly by that clinic. So if that patient was seen in the emergency department and needed to have a follow-up appointment, that list went directly to the clinic so they could call and make these follow-up appointments. It kind of relieves some of that burden in the emergency department of trying to get that patient scheduled, because the primary care clinic knows when these appointments are open, what the availability is, and really has an understanding of, okay, this patient was in the emergency department. We need to figure out where we're going to get them in. So just really looking at that follow-up process that you have. Is your phone call follow-up process working? Is there an opportunity to work directly with the clinics to get these follow-up appointments scheduled? And some of the facilities were able to schedule them before the patient even left the emergency department. The great thing about that is it's directly on those discharge instructions, and so that really can be a helpful indicator. Any other interventions that we talked about that you want to add in, Mindy?
Yeah, the one thing that I just like to touch on as far as the emergency department follow-ups, a big thing that I think we need to focus on too is documentation of those phone calls. If you try to attempt to make a phone call and you did not get an answer, document that. Okay, how many times should we try to call the patient? Document. So then the next person that comes on knows, hey, we did try to call this patient. We didn't get through. Okay, we can try again. Another thing too, as far as, even if that list goes to the clinic, also is documentation. So even if ER needs to look at something, they can see that, yes, an appointment was made with their PCP. So a big, huge thing that I see is lack of documentation. And so I would just really focus on, if these things are if these things are completed, to go ahead and document that somewhere in the patient's chart.
Thank you. All right, so some promising practices that came out of our affinity group. We've kind of mentioned discharge instructions already, but are your discharge instructions clear? In that sense, meaning, you know what, Mindy and I know what a PCP is, but does your patient know what PCP stands for? Or do we need to be really particular and spell out primary care provider, or even go to the further extent of saying, follow up with your doctor's office? For some people, that PCP verbiage may be totally confusing to them, and they'll be very hesitant to ask what that means. They'll just nod their head and say, okay. Something else that we found to be a great promising practice is, we know that once you get in the patient's record, you can quickly print out some discharge instructions based on their diagnosis. But can you customize them? Make them customizable to what the patient needs to do, what the next steps are. And then getting a signature that, yep, for one, I got my discharge instructions, and two, I understood that. So whether that means having a bit of a teach back opportunity where the nurse explains the discharge instructions and then says, can you tell me what you heard and then sign this? Or looking at opportunities there. The other big one from our affinity group was utilizing data to understand needs. So a lot of rural departments don't have ancillary services 24 hours, so that means they get called in after hours. What are your callback times? Are your ancillary service team members getting back within those callback times? Are we really watching that? If we say it's 20 minutes, are we monitoring to make sure they're back in 20 minutes? And then looking at times such as, okay, we call them back, what's the order time to the actual patient test done completion? That could be one of those things that leads to that frustration and a patient leaving AMA or those left without being seen situations because ancillary services was holding up or jamming up your ED department. So really to monitor that. And then looking at your level 4 and 5 ESI visits. You know what, great, we can record and copy that we have X amount of level 4 and 5s and track it that it's accurate. But are we really understanding our data for level 4 and 5s? Is there peak times that we're always seeing level 5 where maybe we could implement some after hours clinics, walk-in clinics, etc. And looking at opportunities such as that. Anything else to add on that one, Mindy?
No, I think you covered it really well.
All right. Something we did from the affinity group, and if you're interested, these will be available through Comagine, the group that we work with at PATH, is we did key takeaways. So each session recapped what we talked about, what the facility shared. We shared resources. So if it came from a facility such as their patient education, posters for walk-in clinics and after hours, that type of thing, or provided resources in these key takeaways that had something like the ESI handbook. So there was a quick access resource for really determining things like education, how we're doing it, that type of thing. So that is really what our affinity group was, and a quick rundown of some practices to maybe look at or things to consider for your facilities that maybe could help utilization. Anybody have any questions?
Thanks, Jess and Mindy. Just a reminder, you can throw your questions in the chat box. I was curious, and I know you just touched on it right at the end here about, seeing people using the emergency department on routinely, like on a Friday. I mean, obviously we know weekends EDs get used more, but has there been some data, reviewing data of the visits to help determine when those urgent care options might be better used?
Absolutely. That becomes a key part of your emergency department utilization measures, is really monitoring that. Maybe it's a Wednesday at 7 o'clock, that's your peak time. Well, that's when we need to consider these after hour care options. Or like Stacy says, maybe there's a whole lot of level 4 and 5 patients that come in every Saturday morning, where that's probably when we need that walk-in clinic or urgent care clinic opportunities. And also we understand that those aren't readily available in the rural setting versus somewhere, let's just say like Sioux Falls or Rapid City. So
there's definitely some added challenges around rural and with workforce too right now. So I thought there's a lot of great information. That communication really is a key, and documentation as well. Anyone else have any questions? Feel free to add them in the chat.
I see Lisa Grun has her hand up. Do you have a question, Lisa?
Hey, thanks,
yeah.
Cindy. Yeah, this was fantastic. I'm at the Alzheimer's Association and do similar QI projects with hospitals, and we see similar outcomes related to access to care. So I was thankful that you detailed that so well. I'm wondering if you had any discussions following the outcomes about potential geriatric emergency department designation. I think South Dakota and North Dakota are the only, maybe almost only two that don't have that designation yet. And I think it's a matter of shifting culture or making people aware. And I just love to hear what conversations you've had around that.
Mindy, do you want to take it or you want me to?
That is one thing that we didn't really touch base on, unfortunately. And I know that is a big one too. Jess, do you remember or recall anything discussed in our sessions that?
No, and really through our affinity group, it was focused on really some utilization measures and focusing around that population, especially when you're considering the IHS population and how they care for and think about their elders, is something that absolutely needs to be explored and expanded through IHS and South Dakota. I have no doubt in that.
Perfect. Well, let's all gravitate together. We'll figure it out.
Right. That would be amazing.
Put it on the list for sure.
Yep.
Other questions?
Oh, sorry. I was just going to ask, are there any other questions?
Mindy and Jess, if you guys wouldn't mind throwing in the chat box, so if you have it available, a link to the resource that you were mentioning. Otherwise, I can add that into the follow-up email that I'll send out later this afternoon.
They
There's-
actually are not being released on the Comagine website until sometime in April.
Oh,
So we
okay.
can certainly get that out. If somebody would like to see those key takeaway documents sooner, please reach out to us and we can share those through email messaging.
Okay,
Yep. Just go ahead and email us and we can get them to you.
sounds good. So we are getting close to the 12:30 mark. So I want to thank you again for sharing your best practices and insights, those experiences you're having on a national level. Being able to pull all of those groups together really helps everybody to share those best practices and understand the challenges, help us realize we're not in alone for sure. And so appreciate your time. We do have, this is just the first of our best practice series sessions. So there will be additional sessions every week through April 18th. So we have a variety of different options. Some of them are talking about substance use, Narcan distribution through pharmacy. We have some talking about innovative ways of helping transition from treatment centers back into the community. And we are also featuring one of the community health workers and talking about how their work can help all of us understand the proper ways to use our healthcare services. And that's really the goal for this series, is try to talk through some of those sessions. So if you have a best practice topic that you'd like to see us present, we'd love to hear those ideas as well. So you can feel free to reach out to me. I'll put my email in the chat box here. And we also ask that if you just take a minute to complete our evaluation, and I'll put that evaluation link here. All of the recordings will be posted on the SDFMC Best Practice Briefs website, and you should get an email with that recording before the end of the day. So I'll ask one more time, any questions for Jess or Mindy before we end our session today? All right. Thanks everyone for joining. Looking forward to seeing you all again next week. Have a
Thank you,
great
guys.
afternoon.
Thank you.
Thank you.